I'm a neonatologist, so I know. That was my next part of my talk, is to say I'm here because I've started a collaboration about 6 or 7 years ago with people you know well, Phil Warwick from Purigen and Rob Kearney from McGill, and we've had a collaboration using them from Kaiser Northern California, our kind of integrated kind of data systems and their machine learning expertise to help predict kind of HIE with our CTG tracings with that. And many things that I was going to cover have been covered in more detail and better than I could have with that, so I'll kind of go quickly through some of those. Okay. So, as we were just talking, that is most of all the, AI, CTG models, they all use pH as their outcome. And as we were just talking, this is potentially a problem because pH does not necessarily mean brain injury. We've talked that you can have injury without a low pH. Kids who have a low pH may not go on to have kind of a brain injury. And ultimately what when I get the baby or the parents are concerned with, they're concerned about kind of brain injury. So is this really an opportunity for us to kind of iterate on using acidemia and incorporate other outcomes that are more reflective of neurological injury, so that we're really kind of reframing what we're saying is, are we trying to predict acidemia, or are we really trying to predict or prevent brain injury? So the kind of layout of my talk today, I'm just going to talk a little bit about why we've used acidemia, why it falls short, which has a lot been covered before, and then what actually matters, and then a little bit about implications for kind of AI CTG models with that, and just a tad bit on kind of a path forward. So, this kind of physiological cascade, you guys are all familiar with. Various iterations of this have been shown at this talk, already. And what we're trying to really look at, is going from fetal hypoxemia to HIE along that pathway. And along that pathway, there's lots of compensatory mechanisms that we try to pick up in our CTG tracings. And when those compensated mechanisms start to become decompensated, then we start to see lactate accumulation. And if that lactate gets to be too much, then it goes on to cause myocardial depression, cerebral hypoperfusion, neuronal energy failure, and then some secondary energy cascade, and we get HIE. So I think the logical choice had been in the past, we choose lactate because we're choosing something before we have, get to the injury that we can intercede in. But is it possible to use other outcomes like HIE as our outcome and train our models on that? And does that give us kind of a better predictive value? The big question is catching something that much later, are we going to be able to intervene before we get there, or has everything already taken place? So just to kind of orient you through the clinical continuum of hypoxic injury, we think about phase 1, that's our detection phase. That's when we're looking at the CTG tracings. There's lots of noise in there. We're trying to predict what's happening. Phase 2 is really that diagnosis, and what we've really been using has been the umbilical cord blood gases, kind of for that diagnosis. But there's also the neurological exam, and the neurological exam may actually correlate much, much better with kind of the brain injury. We move on to phase 3, is really the short-term impacts, and that's what we're dealing with in the NICU and getting closer to kind of some meaningful outcomes, whether the baby needs hypothermia, whether there's other kind of organ kind of dysfunction, they need respiratory support, and then eventually phase 4 is really the long-term horizon, really what it looks like at 20 years out, and that's what the parents are kind of worried about. Am I going to have a good baby? Am I going to have kind of problems there? So what we kind of have to figure out is, if we're training a model on a phase 2 kind of outcome, how well does that correlate with the long-term kind of outcomes? Because if it doesn't correlate really well, is it as useful as having an outcome earlier on that does have kind of better correlation? Many in this room have devoted their life to these models and using pH, and there's a good rationale behind it. Everyone, they're objective, they're reproducible. A pH here is the same as it is, in the United States. There's not a lot of difference there. There's biological plausibility. It's on this pathway towards injury. You're going to see the lactic acidosis and the lower pH before you have kind of injury. in many ways, it has good temporal specificity, where you're seeing the change in the pH and getting that before kind of delivery. And then, as the last presenter showed, it's been linked to short-term morbidity. There's a good kind of correlation with that. And then lastly, there's a feasible sample size that you can use compared to kind of HIE for looking at machine learning with kind of, depending on what your threshold is, anywhere between kind of 1 to 2.5%. This is just actually showing some data from Parkland Hospital, one of the larger delivery hospitals in the United States, and just looking at the correlation that they showed in their kind of population of 90,000 with kind of the ACRI criteria for acidemia, pH of less than 7 or a base deficit of greater than 12. And what they show is a nice correlation between these short-term outcomes: NICU admission, ventilator support, seizures, and HIE. When you look at the relative risk, it's quite high. It's 100. But the key here is looking at what is the incidence in the acidemic group. It's still only 3.6%. So while the relative risk is quite high, the actual absolute risk is low. So, what are the weaknesses and limitations? We've kind of just talked a lot about them, but it's really the poor prediction of kind of long-term outcomes that's most concerning. So this is just kind of a graphical illustration of what we were kind of talking about before. Is you have severe acidemia. What's the risk of having HIE? Well, that's only 3.6%. So if you're thinking about the positive predictive value of that, it's quite low, which has a lot of implications. If you're talking to a parent and telling them, here's what my model is showing, it's saying that you're going to have acidemia, a lot of times they're thinking, my baby is going to have neurological injury, but acidemia and neurological injury are two different things. And it's hard to kind of explain to them when you're trying to decide on thresholds for intervention that what the actual risk actually kind of is. So we need something that's kind of more tied to outcomes, which makes it a little bit more understandable and reasonable for the parents and clinicians to kind of interpret and kind of put action to it. Now, I will say, when I look at this, the other reason can also be when we look at these studies, it has really low positive predictive value, but there may be a bit of a treatment paradox there, as well. So it could be because, we don't see these outcomes because people are responding to things that are going on. The baby's coming out, they're acidotic, but they haven't gotten to neurological injury, so it's in a way a success. It's hard for us to see in this big data like this, what is what kind of with that. But it's definitely a concern about the poor kind of association with the long-term outcomes. Other things that it misses is some of the complexities of encephalopathy. So if we look at clinical encephalopathy and seizures and MRI patterns, those can be more strongly associated with long-term outcomes. As you saw the laundry list from the last presentation, acidemia is not specific to intrapartum events, so you may have acidemia for many other reasons besides just kind of impaired perfusion to the fetus. And then these thresholds are very arbitrary depending on the study that you look at. You're going to see different kind of you're going to see different numbers for the incidence of these outcomes. And I thought this study was interesting. So this is, I believe, the Swedish study that they looked at, their population-based study. And what they really saw is that these thresholds really matter. You can see when they just looked at a pH of less than 7.05, you can see the incidences of CP and epilepsy and intellectual disability. But when they looked at it stratified by the pH really matters for that association, as when you get down to 6.95, it really kind of shoots up there. So this has major implications to how you're training your model and what pH and what threshold that you're using. And then the other things that we worry about kind of with pH is they may miss things as well. So as we've talked about with many of these talks before, there may be an earlier hypoxic event, maybe it's even before they come to the hospital. You have neurological injury that's sustained, but then you have some oxygenation that's restored, and the acidemia naturally corrects. And then you get a cord blood that is missing that because there's no acidosis. and it's kind of masking that early injury. And you may also get the opposite, where there's a terminal catastrophic event, where there's a sudden event, like a cord obstruction from prolapse or uterine rupture, and that's causing injury, but it occurs so quickly and before delivery, before that lactic acid really gets a chance to circulate to the placental cord, and the cord pH reads normal as well. So what other things can we use? So we said that maybe we need to add on to acidemia. So we think about, could we use like the APGAR score? And as a neonatologist, one of the first things I always get like asked after delivery from the opposite side is, what's the APGAR score with that? And I always find it interesting when you look at kind of the APGAR score, in the 50s, it's really meant to look at just at the response to resuscitation. It has the advantage that it's universal. We get this on kind of every baby, but it's really reflecting physiological transition at birth. It's really not diagnosis of asphyxia. It doesn't predict individual neurological outcomes, and then it's highly influenced by gestational age, medications, anomalies, and there's a lot of subjective elements, especially in the babies who are being resuscitated, and we're kind of giving things, there's no kind of clear, what do we score the respiration if I'm actually giving the baby's breaths, with that. So, there's a lot of subjectivity in the APGAR scores, and when you look at kind of their correlation with long-term outcomes, really horrible ones, if you look at a population level, they do correlate with increased risk of CP, but again, their absolute risk is fairly low. So it's just kind of a snapshot of transition and not really a measure of brain injury. So moving on to, can we use hypoxic ischemic encephalopathy as an outcome? And when we talk about HIE, I think the one important thing is to kind of start with is, what is that definition? Because lots of times, I think in the literature, neonatal encephalopathy gets conflated with HIE. And neonatal encephalopathy is that bigger umbrella. So it incorporates not only encephalopathy from HIE, but from other causes, from metabolic, from infection, from genetic kind of disorders with that. And what we really want to look at is, as using as an outcome, is really hypoxic ischemic encephalopathy. Otherwise, if we're training these models with these other particular insults that are causing kind of encephalopathy, it may not have the same kind of findings with features that are related to the outcome, or not be related kind of at all. So for HIE, we're taking advantage of the information with the acidosis, but it's kind of a two-pillar diagnosis. You have to have that acidosis there, but you also have to have a diagnosis that's showing signs of encephalopathy. And how do we determine or grade encephalopathy in babies? So really the basis for this is really kind of the SARNOT score. There's different modified versions and versions in the UK, I think, as well. And the SARNOT score, the severity really correlates well with neurological outcomes. A SARNOT score of 1, almost universally these kids are okay. A 2, there's a kind of a mixed bag. And stage 3, those kids often are very severely kind of affected. And I think as we're kind of talking about this, it's kind of important to know, like, well, what is this kind of based upon, and what's the evidence of the SARNOT exam? And it's super surprising when you like look back at it. The SARNOT exam was actually developed in the 70s by, I think, a husband and wife kind of neurologist. And the whole SARNOT exam was based upon like 21 infants. And what they basically did is they just kind of observed them after what they called, some kind of an event of fetal distress. And it was very light in APGAR, that was very low, or very undefined with that. And they followed them just longitudinally with serial neurological exams to see how they progress. And so they re-examined them every 12 to 24 hours for the first 6 days, and then every other day until they were discharged or they died with that. And what was interesting from that study, they kind of identified 3 clinical stages. And you can see up on the left here is kind of the different stages that they saw. And it was based upon consciousness, their posture, their reflexes, some autonomic functions when they had seizures or encephalogram. And really, when they kind of described this, it was not as severity, but it was stages. Some babies would only move to stage 1, some babies would go into stage 2, some babies would get all the way to kind of stage 3. And in their very small sample of 21 infants, what they did find is the infants that advanced all the way to stage 3, these were all infants that were kind of devastated or died. The infants that never progressed out of stage 1, they all did well, and the babies who were in stage 2 but less than 5 days, those infants actually did pretty well. Subsequently, there was a lot of studies in the 80s by Feiner and Robertson that looked at the SARNOT kind of staging in somewhat larger cohorts. I think the largest one was only like about 160, but remarkably, all their outcomes correlated very well. What they kind of found looking at later outcomes, looking at outcomes at 2 and 3 years of life, is that if an infant didn't pass didn't go past stage 1, they all did well. If they got to stage 3, 100% had some handicap, and about 21% in kind of stage 2. So this was kind of the basis for kind of how we score neurologically. But then we have really the game changer is when therapeutic hypothermia kind of came into existence. It really impacted kind of the outcomes in a great way, but it also had a big effect, and I think this is important if we start to use HIE as an outcome in how people kind of defined HIE with that. So for the study, and based upon kind of the prior outcomes, they weren't interested in looking at kids with stage 1 or mild encephalopathy, because no matter which group they were in, they were going to do well. So you just need a bigger sample size. So they really focused on kids that they thought would have a poor outcome. And so to qualify for the studies, they needed to have moderate or severe encephalopathy, and that was deemed to be 3 of the 6 characteristics in the modified SARNOT score to qualify for those categories with that, and usually a base deficit of less than 7, or base deficit of greater than 16, or a pH less than 7. But what also kind of changed as we kind of classified these kids for the trial is, in order to receive cooling and have its effect, we knew that there's a critical period of identifying these infants in the first 6 hours of life. They needed to be cooled to have the beneficial effects. So as far as our kind of definitions and how we kind of discussed like HIE, well, now instead of watching these infants for 7 days and how they progress, in the first 6 hours, we're making a determination, are they mild, moderate, or kind of severe? And I think, as you use data sets that have HIE, this is an important thing, because this is probably what you're gonna kind of see is more kind of these definitions, because this is what we're using clinically. The other thing the studies had is a benefit of is, I think if you, prior to the cooling studies, when you kind of looked into the charts of kids with HIE, documentation was kind of poor. But now that we had an intervention and everyone didn't want to miss it, and we wanted to identify that, now the documentation got much better, so and much more useful. So for example, where I'm at Kaiser, we have like a best practice alert that pops up if there's a low APGAR score or a low pH with that, to do an enhanced neurological exam, and there's templated notes there that go through the kind of the SARNOT score. And this many places have kind of done this, which is way better than before, because when you review these charts, they would use an electronic chart that had a templated note, and the neurological exam was like non-focal or that, so they give you very little information. So now you can actually get that kind of information out of the chart and to be used. Now how does the severity, especially in the cooling area of our kind of stage or severity of encephalopathy correlate with neurological outcomes? Am I running out of time? Or? Okay. And so basically it correlates much better. So opposed to what we looked for as far as looking at an outcome of acidosis, in moderate HIE, the death rates, or the rate of death or disability is 26%. That's a lot more actionable when you're kind of telling someone that, or severe is 71%. And the question is, well, can we just exclude kind of mild HIE? Is that kind of not needed, since the earlier studies had shown universally good outcomes? But now the definitions have kind of changed, because we're identifying these kids in the first 6 hours. So when you think about kind of mild HIE, there's been kind of studies in kids who didn't qualify for cooling and looking at their outcomes, and they actually have a lot of deficits as well. So these are also kids that need to be kind of examined. But using HIE is not perfect. We have now introduced a lot of subjectivity with the neurological exam, especially sometimes like right after birth, a kid's gonna look just terrible, but they need to give them time to kind of recover with that. The whole question of using HIE, can you detect it early enough to avert injury and intervene? And then the other thing that gets complicated if you're looking at databases, some people have the urge instead of is just to use therapeutic hypothermia as a surrogate for HIE, but that actually can be problematic because as HIE or as therapeutic hypothermia has kind of been in play, there's been big creep, as clinical creep. So what are the use for the studies as far as for their entry criteria? That's not what's happening out there. We're cooling way more people, so that therapeutic hypothermia may not actually relate to moderate or severe HIE. When we look at our data sets and the kids who got therapeutic hypothermia, some of them we see no evidence of acidosis. It's just the kid's resuscitation kept on going on and they were worried, and so they just cooled the kid and all that. So you have to be very careful with that. And then the other kind of caveat is the criteria for therapeutic hypothermia, well, it includes fetal acidemia. Almost all the criteria also include if the infant's first gas in the first 60 minutes was acidotic as well. And that may be great if there's not a cord there, you have that information, but it also then pulls in play what happened during the resuscitation. If the resuscitation was poor, you may see more acidemia because of that, and that may kind of confuse your outcomes as well. I'm going to skip the next two slides because they were just looking at other things that we can use as far as MRI, MR spec, and EEG to kind of help with that. And then I'll just kind of end it. If we choose to kind of move towards strategies to focus on HIE, and I think the people in the room are the people that help me kind of with this, that have the expertise in machine learning, is how to incorporate HIE into this work, using it as a composite ordinal outcome with acidosis. It's all in the same pathway. So having no acidosis but no HIE, acidosis and HIE, using a multitask learning kind of method where you have a single model with different kind of outcomes, one's for HIE and acidosis, having the acidosis doing the heavy lifting as far as with all the information, and it's on the same pathway, but really optimizing your models for kind of HIE, or using your models using acidemia as a mediator. But then the other important things is I kind of talk about, it's really important to refine that HIE label. Obviously using HIE, you need much larger numbers, so everyone here getting together and being able to collaborate and making these data sets bigger so that HIE can be used. And then I didn't get to it because I'm running out of time, but also if we can incorporate other neurological kind of markers such as like the MRI findings, MR spec, EEG, that actually gives a better categorization and actually correlate even better with neurological outcomes than just the severity.
I'm sorry.
Sure.
But this is great. I think it's really relevant. I think that's a big discussion. I can see how it's going to explode now, and then we have 2 more talks in a panel. This was excellent. You just added the other dimension. I have a lot of things, and I'm going to still behave myself. What do you think is the solution?
Well, I think using one of those combination approaches, we're not throwing out acidemia, but using kind of HIE in large data sets to help kind of hone and kind of optimize that, I think would be helpful.
One of the issues is that outcomes are extremely heterogeneous. So extremely heterogeneous, and the way you define them would define what patterns you can recognize. For example, pH is reasonably easy from data because of decelerations. It's something that is there and it's easier, but it's so I would rather have my child not have low pH. It is a risk factor.
Oh yeah.
So yes, okay. Yeah, do you see what I mean?
Yeah,
and I'll build on that and invite Sophia, because it's your second day. I'm looking at you. It's your second day, so you're not allowed to be so shy anymore. But I wonder, bringing that, it's really important. There was intervention, especially in Europe, that persistently was demonstrating being used in clinical settings in Europe reduces substantially, 50%, if I remember correctly, the rate of low pH plus minus, and that was the STAN monitor, and that was used widely around Europe. And then suddenly we had this, even when we don't think about the clinical trial in US, we had suddenly, the meta-analysis and everything, and saying, okay, we reduced 50% pH plus minus, if it wasn't 50%, whatever it was, a good reasonable percentage. And then we said, but so what? pH doesn't matter. And this meta-analysis, I think, played a very big role in the reduction of use of stans. So I'd just like to know your opinion. And I know I'm taking over, but that's my privilege. And I will expand the discussion because I know it's a big one, but still try to contain it. Can I do this, please? What do you think from Nuventa's point of view, from Stan's point of view? How does that play with pH? What is your honest opinion? Sorry to put you on the spot, but that's actually very important, I think.
Thank you very much for the question and thank you for the talk. So I think one of the first challenges that were with actually develop the STAN machine was what were we going to measure? What was we going to improve? And there Professor Rosen spent a lot of time in looking in the calculation of the metabolic acidosis and using the base deficit in an extracellular fluid to make sure not to pick the wrong babies. But as you say, it's still a sub-measurement. But of course, in the area of evidence-based medicine, everyone is expected in a randomized controlled trial. You need to do the power calculation. You need to have enough cases, and it should also be feasible. I mean, it's a clinical setting where you should produce this kind of data. So there is sort of the reason that metabolic acidosis has been the primary endpoint for those studies. And I think I would need a whole lecture to talk about this randomized controlled trial and why they are so biased. But I will not take the time right now, but thank you very much for the question. Yeah.
I wonder, when we look at kind of pH and kind of the outcomes and all that, and as we talked about, I think with Miko's talk and the influence of something like, like inflammation or infection, kind of with that is like what should that pH level be at, and if there's these other factors that are influencing it, does having an outcome like looking at HIE kind of help avert that so you're not all pinned to just one pH cutoff? It may be very different depending on what other factors are going on.
Yeah, so when it comes to this technology, the reduction of HIE, it was possible to demonstrate that in the quality improvement research, the observational study, where they were included many thousands of cases, and of course with retrospectively comparison of the data before. So there is often the limitation of what we refer to as the evidence-based medicine, because those studies, those observational quality improvement research is not ranked as high as the randomized controlled trial. Yeah. But there we could even see the reduction in the HIE cases.